Good afternoon, everyone. I'm Dr. John Shrigley, the clinical lead for the Canadian Partnership Against Cancer's National Synoptic Reporting Project. And on behalf of CPAC and the Canadian Association of Pathologists, I would like to welcome everyone to today's education session on the new CAP checklist for lung cancer with Dr. Kelly Butnor. Before I introduce Dr. Butnor and we get formally underway, I'd like to take care of a number of housekeeping items. Today's presentation will be approximately 90 minutes in length and will include about 60 minutes of presentation time, followed by up to 30 minutes of questions and answers. The session is being recorded and will be made available to all participants via email once the recording becomes available. Both the live presentation and the recorded presentation are eligible for CME credits using the electronic completion and submission of the pre-circulated evaluation form to pathology@partnershipagainstcancer.ca. Please note that everyone's line has been automatically muted for today's presentation. Due to the large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you are having difficulties accessing the WebEx portion of this teleconference, please call the WebEx support line at 1-866-229-3239. Once again, 1-866-229-3239. To pose a question for the speaker, I would ask you to use the chat box or the chat section on the WebEx screen. For instructions on how to use the WebEx chat window, please refer to the documentation that was previously distributed to you. In order to avoid question collisions, I will pose the submitted questions to Dr. Butnor on your behalf as long as time permits and in the order that they appear. Questions can be typed in at any time during the 90-minute teleconference. In the chat window, please include the following information: your institution's name, the name of the individual posing the question, and finally your question. It is now my pleasure to introduce Dr. Kelly Butnor. Dr. Butnor is presently an attending surgical pathologist at the Fletcher Allen Healthcare Center, Department of Pathology Lab Medicine in Burlington, Vermont, and she is an associate professor in the Department of Pathology at the University of Vermont. Dr. Butnor is a graduate of Duke University in Durham, North Carolina, and is a fellow of the American Society of Clinical Pathologists, the College of American Pathologists, and the International Association for the Study of Lung Cancer. She is a member of the College of American Pathologists Cancer Committee and the CAP's Anatomical Site-Specific Committee on Pulmonary Pathology, and is also the chair of the Thoracic Cancer Protocol Review Panel for the College of American Pathologists. Dr. Butnor is also the author of many academic papers, including the one that outlines the new protocol for lung cancer, College of American Pathology Lung Cancer Checklist, which was published in the October issue of the Archives of Pathology and Laboratory Medicine. Ladies and gentlemen, Dr. Butnor. Kelly?
Thanks very much, John. And I wanted to thank everybody for joining in today. It's my distinct pleasure and honor to speak with you today about this topic. So today's topic is lung cancer reporting, and it's an overview of the new CAP lung cancer protocol. And before we get started, I'd just like to say that I don't have any relevant financial interest to disclose with regard to this talk. The objectives for today's talk are threefold. One of them is to understand the rationale behind the elements that have gone into the new CAP cancer checklist for lung cancer. And I'd like to explore several histologic types of non-small cell lung cancer that may carry prognostic or therapeutic significance, how to recognize these histologic subtypes, what their importance is, and how to communicate that to the clinician so that ultimately the patient gets the appropriate treatment. And finally, I'd like to discuss the changes in lung cancer staging that appear in the 7th edition of the AJCC Cancer Staging Manual. And there are a number of important distinctions from the 6th edition. Some are straightforward and some less so, and I'd like to go through some of the most pertinent ones. So with that introduction, what I'd like to start out doing is selecting some of the elements within the CAP cancer checklist for lung cancer and explore the rationale behind why they appear there and are necessary reporting elements. Now, if your practice is anything like mine, the most common lung cancer resection specimen for definitive treatment that you're likely to see is a lobectomy. But there are several other types of specimens that you may encounter, and they are of importance to recognize because they have implications as far as reporting of margin status. Ones you may be a little less familiar with and wonder why, when you receive one, the surgeon elected to do so are procedures such as wedge resections and removals of segments of the lung. And what these are done for most typically is patients who are still amenable to surgical treatment of their lung cancer but don't quite have enough pulmonary reserve to undergo either lobectomy or pneumonectomy. It is recognized within the literature that these partial procedures are not as good as lobectomy in terms of long-term survival and outcome, the problem being most typically local recurrence. But it is a type of procedure that you're likely to see on occasion depending on your practice and your surgical colleagues. And what becomes important is that you won't be having a bronchial margin. Rather, it's your parenchymal stapled margin that's the key. So understanding what type of procedure has been performed and what kind of specimen you're dealing with will really help you to report the specimen accurately. Now, a new category that we have in the protocol is specimen integrity, and that's not only for lung cancer, but you're likely to see it in some of the other types of cancer protocols for the other organs. And we thought this was important to give a sense of exactly what the pathologist is dealing with and the difficulties they may be encountering in terms of reporting all of the necessary elements, in particular things like margin status, that may be very difficult to interpret if the specimen is fragmented in some way. So this particular element within the CAP checklist allows you to give a segue, if you will, in terms of commenting on why a particular type of element elsewhere in the report can't be determined accurately due to the fragmentation. The next element that is of great importance, all the more so in the new AJCC 7th edition, is tumor size. Now, with the advent of high-resolution CT scanners and lung cancer screening protocols that have come in place, now more than ever we have begun to detect smaller and smaller lung cancers that are more and more amenable to surgical resection. And the data that has been gathered from the International Association for the Study of Lung Cancer on these small tumors has shown that, as one might expect, smaller sized lung cancers do better than larger sized ones. And this has in fact led to a splitting of the T1 category in the TNN system based on size dependency. So it's really more critical than ever to accurately determine the measurement of the tumor. And this brings up an important point that what one sees grossly isn't necessarily reflective of the actual tumor size. And problems that you can run into include peritumoral fibrosis or surrounding obstructive pneumonia that actually might falsely give you an impression of a larger tumor size than it actually is. This is just one example. It's a patient with idiopathic pulmonary fibrosis in which a small carcinoma happened to be found. And there was surrounding fibrosis making grossly the measurement of the tumor size larger than what was seen microscopically. So in my practice, what I like to do for tumors that won't fit in one cassette to be examined histologically is to block in the tumor in a sequential fashion such that you're able to map out the exact dimensions in case you run into the problem of peritumoral fibrosis or surrounding obstructing pneumonia that creates a falsely elevated impression of tumor size. Another category that has caused great consternation in the past is the issue of satellite tumor nodules, as discussed in the 6th edition of the AJCC staging manual, and now are being termed separate tumor nodules. It's easy when one has two tumor nodules of different histologies to say that these are different primary tumors and stage them accordingly, but every so often you run into the example of you have two lesions that have very similar histologies, and how should you manage and stage those appropriately? Well, in the 6th edition of the AJCC, what one was forced to do was call them T4 lesions, but the study of the data from these lesions actually showed that they behaved more like T3 lesions than T4 lesions. So this has actually been downgraded to T3 in the 7th edition of AJCC. In a similar fashion, in the 6th edition of the AJCC, if one had multiple tumor nodules not in the same lobe, but in separate lobes of the same lung, one was forced to call them M1 in the 6th edition, but now, because we have data showing that they behave more like T4 tumors than M1 tumors, they have also been downgraded similarly. There's been a recent paper that's maybe of interest to you in terms of how can we try to distinguish these similar histology multiple tumors in the same lung or in the same patient. And the only way currently with any amount of certainty is through research means of comparing the genetic signatures and genetic aberrations in the tumors. Now, there certainly are, and some of you may be familiar with the criteria of Martini and Melamed that are outlined in the AJCC manual in terms of assessing whether something is intrapulmonary metastases or synchronous primaries. But in this recent article, what was done was very careful histologic assessment of tumors that at first blush have relatively similar histologies. And through this detailed assessment, comparing that with the molecular data on separate tumor nodules in the same patients, the authors were able to find that through this detailed histologic assessment, they were more accurate or more in correlation with the molecular data than by using the criteria of Martini and Melamed. And what those criteria are still need to, or what this detailed histologic assessment entails, it still needs to be nailed down more firmly. But some of the things that the authors discussed in this paper were looking at the histologic features in terms of not only the predominant histologic pattern within the lung tumor, saying that if two tumors are of a mixed subtype, which is the most predominant pattern within that. For example, one tumor might have a predominant acinar component, while the other separate tumor nodule may have a more papillary component that may lead them to say that they are synchronous primaries. But they also went so far as to look at other features like what the second most predominant histologic pattern was, the degree of cytologic atypia, tumor necrosis, and a number of other histologic features. So it'll be interesting to see if there are further papers and study using detailed histologic assessment to help us with this difficult problem. But nevertheless, if a tumor in a patient has a different histology from a second tumor nodule in the same patient, we consider them synchronous carcinomas, and the required data elements in the checklist should be reported for each of those tumors separately. And the way in which the TNM category is designated is with a suffix after the highest T category for those tumors and with the number of tumors that are in the patient. Moving on to histologic typing of lung cancers, traditionally what has been asked of us as pathologists is a pretty black and white question on the surface. Is something a small cell carcinoma or a non-small cell carcinoma? Now, as all of you know, that's not such a straightforward topic in and of itself, but the distinction was based traditionally on how these carcinomas were treated and their clinical pathologic characteristics. Small cell carcinoma, as you are familiar with, unfortunately usually presents at an advanced stage, whereas non-small cell carcinoma is more resistant to traditional chemotherapy. Therefore, the treatment of small cell carcinoma, because it's not usually amenable to surgery, being present at an advanced stage initially, is chemotherapy and radiation. Whereas non-small cell carcinoma, the mainstay of treatment, if the patient is a surgical candidate, is surgery with or without neoadjuvant chemotherapy and radiation. But in today's practice, the distinction isn't so black and white with the development of targeted drug therapies. Certainly, we still want to recognize small cell carcinoma for what it is, but it's no longer satisfactory to just say something is a non-small cell carcinoma. We need to be going the extra mile for our clinical colleagues and our patients in terms of guiding the hand of management and trying at least as best we can to distinguish adenocarcinoma from squamous cell carcinoma and then the other types of carcinoma. This bipartite distinction within non-small cell carcinoma will certainly go a ways towards helping select targeted drug therapies for these patients, and I'll touch on those a little bit later in the talk. And even within the subcategory of adenocarcinoma, we're beginning to recognize through careful clinical and molecular analysis that there appear to be subcategories of adenocarcinoma that bear special prognostic significance, and I'll touch on those in just a moment. Going back to the issue of small cell carcinoma, we're often used to seeing small cell carcinoma because they are not usually amenable to resection just on a transbronchial biopsy specimen. And when we do see small cell carcinoma in a resected specimen, I'd like to point out that it can have some subtle histologic features that are a little bit different that may make you think twice about that diagnosis. And it's important to recognize that resected small cell carcinomas look a little bit different than those seen on transbronchial biopsy. Other critical thing about small cell carcinoma is based on the data from the International Association for the Study of Lung Cancer. It's been found that traditionally the staging used, limited versus extensive, really should be replaced by the AJCC TNM staging scheme, just as we use for non-small cell carcinoma. It does appear to be equally applicable to small cell carcinoma, and they should now be staged as such. This may be important in your interdisciplinary conferences with your clinical colleagues in terms of getting them up to speed on this new staging of small cell carcinoma. Now, this is a type of appearance we're used to seeing on a transbronchial biopsy of small cell carcinoma, and all the cytomorphologic features are there. The scant cytoplasm, coarse chromatin, inconspicuous nucleoli, nuclear molding, crush artifact. But in resected cases, that crush artifact isn't as apt to be there by the forceps of the transbronchial biopsy, and we have greater preservation, yielding, in some cases, not conspicuous, but at least visible nucleoli. And I don't want people to be dissuaded from a diagnosis of small cell carcinoma if all the other features appear to be acceptable for that based on the seeing of occasional small visible nuclei. Just to remember that when you're dealing with that occasional small cell that happens to be surgically amenable to being resected or in a patient in whom they didn't do a pre-surgical biopsy, assuming it was a non-small cell lung cancer, and then when the specimen comes out, it does in fact turn out to be a small cell carcinoma. In terms of non-small cell carcinomas that have special prognostic or therapeutic significance, I'd like to point out several to you. The first being non-mucinous bronchioloalveolar cell carcinoma. And remember, the definition of BAC is much more restrictive than it used to be in earlier editions of the WHO classification. Now it being no evidence of stromal, vascular, or pleural invasion. This is an area of confusion that persists among pathologists out there who may not be familiar with the more up-to-date definition of this. And I'd just like to emphasize that at the periphery of many adenocarcinomas of the lung, one is apt to see this lipidic type of growth pattern where the neoplastic cells grow along the alveolar septa, but more centrally a more solid or acinar or mixed subtype adenocarcinoma. So don't let the presence of a focally lipidic growth pattern, as I'm showing here, push you into calling something a BAC when the rest of it doesn't meet those definitional criteria. But nonetheless, some studies, particularly those from the Japanese literature, have shown that there seems to be an association of the BAC histology with tyrosine kinase sensitive epidermal growth factor receptor mutations. And this is, of course, important because there has been several drugs developed, the TKI or tyrosine kinase inhibitors, that have shown efficacy in patients with these EGFR mutations. In the Western literature, this association hasn't been as strong, and the data is somewhat mixed on this, but it certainly would be something to consider and alert your clinicians to if the patient really does meet criteria for a non-mucinous BAC. They may be appropriate patients for considering these tyrosine kinase inhibitors. Another histologic subtype of adenocarcinoma that bears recognizing is papillary adenocarcinoma. There have been some studies in the Western literature that a major papillary component in adenocarcinoma is associated with these tyrosine kinase sensitive EGFR mutations. These are in contrast to mucinous bronchioloalveolar carcinoma. These tumors do not show EGFR mutations and instead exert their neoplastic potential through KRAS. So it's an important distinction to make when you're signing out a BAC and alert your clinician. The clinicians seem to be familiar with EGFR mutation association with BAC, but what has not apparently gotten out into the clinical literature, unfortunately, is it's really just with the non-mucinous subtype, and the mucinous subtype does not have these EGFR mutations. So it might be a cost savings measure to explore with your clinician to ask for EGFR testing on a mucinous BAC, that the likelihood of finding a mutation would be virtually nil. Another important subtype of adenocarcinoma to recognize is the micropapillary variant of adenocarcinoma. The studies, just like those of micropapillary carcinomas in the breast and in the GU tract, have found that the survival is significantly poorer with these than for similar stage tumors of other subtypes of adenocarcinoma. there's both higher rates of pleural invasion and nodal metastases than you would expect for a tumor of the same size of another histologic subtype. It's not entirely clear why this is so, but some molecular data is suggesting that there's some differences in cell-to-cell adhesion properties with these micropapillary carcinomas that allow them to exert a more malignant potential than other histologic subtypes. Now, in the histologic type section of the CAP protocol, unfortunately, micropapillary adenocarcinoma does not appear as a separate line. We were just going with the recognized WHO subtypes, and the WHO does not currently separate micropapillary adenocarcinoma as its own subcategory. Hopefully, I would think in the future that that would be the case, but if you have a tumor that has a significant micropapillary component, it would do your patient a great service to mention that, at least in a comment, or feel free in the histologic subtype to include that, even though it's not listed as a choice specifically in the CAP protocol. Just to remind you that the distinction between papillary adenocarcinoma of the lung and micropapillary adenocarcinoma rests on the presence or absence of fibrovascular cores, papillary having them and micropapillary lacking those fibrovascular cores. Another thing to keep in mind with regard to histologic typing is that carcinoid tumors, clearly from the data, it has been shown that they have the capacity for metastatic potential, and it appears that the categories for TNM for both small cell and non-small cell carcinoma can also be applied equally well to carcinoid tumors, and therefore they should also be reported with TNM staging from going forward. With respect to histologic grading, there's a four-tiered system as there is for many organ sites, ranging from well-differentiated to undifferentiated. And it's appropriate to use the least favorable grade or degree of differentiation when assessing and assigning grade, rather than going with the most predominant pattern. This will allow the worst histologic grade to drive the information, and as we all know, it's probably the worst histologic grade area of the tumor that's the most likely to metastasize, so we want to reflect that accordingly. If the tumor does have any discernible squamous or glandular features, that's really by definition doesn't fall into the category of undifferentiated, and so we should assign one of the lower grades to that, well, moderate, or poorly differentiated. By definition, small cell carcinoma and large cell carcinoma are undifferentiated or grade 4 tumors. Now, a category that's in the CAP protocol that has caused a lot of confusion in the 6th edition of the AJCC is the presence of visceral pleural invasion. In the past, although it appeared as a T category element in the 6th edition of the AJCC, no good histologic criteria were outlined in the lung cancer chapter as to what constitutes visceral pleural invasion, leaving it essentially a free-for-all of what it really constituted. But a welcome addition to the 7th edition of the AJCC staging manual is that some criteria have been put in place. We now know that tumors that extend beyond the elastic layer of the visceral pleura behave significantly worse than those that are confined in the lung or beneath that elastic layer, even if they are in continuity with the pleura, that being that there's no intervening lung parenchyma between the tumor and the pleura. As long as they don't cross that elastic layer, they seem to behave just as they would if they were confined to the lung parenchyma itself. In addition to that, we've also found that tumors need not extend to the visceral pleural surface to have that worse behavior. Really, the line of demarcation in terms of impacting behavior is that crossing of the elastic layer. So tumors that would otherwise be categorized as T1 by size and other criteria, but penetrate through the visceral pleural elastic layer, are now up-categorized to T2A. Also, if there is direct invasion across a fissure, it is categorized as T2A as well. There is some controversy regarding this particular element in that some studies have shown that tumors that do invade across a fissure behave more akin to T3 tumors, but there are other studies that suggest they behave more akin to T2 tumors. So in the current category of the 7th edition of AJCC, these are going to be categorized as T2. And as more data becomes collected about these tumors, that assessment may be revised in the next edition of the AJCC. Now, I want to emphasize that we're talking about tumors that are in direct continuity with the pleura. Those tumors in which there are separate foci in the pleura are an entirely different behavior, and they should be categorized as M1 tumors instead. Now, to accurately assess the visceral pleural invasion, it's important to understand a little bit about the anatomy of the visceral pleura. It has 5 layers. The layer that's closest to the pleural space is the mesothelium, a very thin layer of these cuboidal to flattened cells that may be difficult to see on light microscopy alone. Beneath that is an elastic layer. This may be the thickest layer of elastica in some patients, or it may be somewhat thin. It varies from person to person. Beneath that is a connective tissue layer in which you are able to see multiple lymphatic channels. Beneath that is another elastic layer. In this particular patient, this layer happens to be somewhat discontinuous and thin. And then finally, there's another connective tissue layer deep to that, and beneath which is the beginning of the lung parenchyma. Now, you'll note that the criteria for visceral pleural invasion are penetration through the visceral pleural elastic layer. And that still, even though we now have criteria and a definition for what constitutes visceral pleural invasion, leaves a little bit to chance, because in the normal setting, the anatomy of the visceral pleura is such that there's 2 elastic layers. The data from studies looking at visceral pleural invasion by otherwise T1 tumors isn't granular enough. That is, people haven't looked specifically whether the penetration of the deep elastic layer or the more superficial elastic layer is the actual one that's most important for driving the poor outcomes with these patients. But a decision was made that if there is invasion of whatever elastic layer appears to be thickest in that particular patient, then that patient should be assessed as having visceral pleural invasion. So it's not a perfect definition at this point, but at least we have some guidance. And for the most part, in my experience, it won't be too difficult with the use of elastin stains to pick out what you feel is the most thick elastic layer and whether or not tumor penetrates that. If there's any question, elastic stains can certainly be a great help in this endeavor. I'll show you one difficult case, though, and I ask people, is visceral pleural invasion present in this case? We can see that tumor abuts the visceral pleura. There's no intervening normal lung parenchyma between the pleura and the tumor at the bottom of the slide. And we can see a few nests of tumor cells that course up into the pleura itself. And in this particular patient, the elastic layer is somewhat broad, and there looks to be duplication of the elastic layer, and it looks to be somewhat discontinuous. But I think what we are told from the criteria that are outlined in the AJCC manual is to err on the side of caution and be very conservative in our assessment of visceral pleural invasion. If there is an unequivocal, definitive crossing of what you feel is the visceral pleural elastic layer, then to retain that as the lower T category and state that visceral pleural invasion is absent. In my experience, there are those few cases in which visceral pleural invasion assessment is just truly indeterminate, even with the use of elastin stains. I'd say in my particular experience, less than 5% of cases, but there are those cases that are very desmoplastic, and they themselves incite a desmoplastic response in which a lot of elastin is caught in. But again, I just emphasize that according to my understanding and reading of the assessment, that we should be very conservative unless tumor crosses the visceral pleural elastic layer, not to call it present. You can really see how helpful elastin stains can be in some of these cases. On H&E, the tumor here is in close apposition to the visceral pleura with no intervening normal lung parenchyma. And it looks for all the world like visceral pleural invasion would be present, but the elastin stain nicely highlights a sharp, continuous band of the elastic layer that's above the tumor, and the tumor is contained within it. So here I would assess visceral pleural invasion as absent. In a different case, you could see that on the H&E stain, the tumor appears to be somewhat distant from the visceral pleural surface, and you would be surprised probably to see how deeply diving the visceral pleural elastic layer is in this case, with the tumor unequivocally penetrating on both sides of the visceral pleural elastic layer. So in this case, visceral pleural invasion is present. If this tumor was an otherwise T1 tumor, this would upcategorize it to a T2A. Moving on to the realm of tumors that are a little bit larger and begin to invade structures that are outside the lung. It's important to document what other structures are invaded by such tumors so that the T category can be accurately assessed. And oftentimes this requires careful consultation and conversation with the surgeon who is doing this type of procedure, in that they'll submit a portion of chest wall attached to the specimen as an en-bloc resection. So it's not your usual type of specimen. The surgeon will be helping you to designate the margins of the specimen and hopefully giving you a heads up that it is an en-bloc resection, and so that the chest wall margins can be properly assessed, or mediastinal margins, or whatever types of other soft tissues are coming along with the specimen. Visceral pleural invasion will upcategorize a tumor to T2 that was otherwise T1, but if there is invasion across that pleural space into the parietal pleura or the chest wall adipose tissue, that upcategorizes a tumor further to TT3. One of the areas that causes consternation in terms of assessing tumor extension is distance from the carina, as well as distance to some other structures that may not be apparent to the pathologist without discussing that with the surgeon or the radiologist. I liken it to the issue of vocal cord fixation when you're signing out a laryngectomy specimen, in which we really do require some clinical radiographic correlation for some of these more extensive tumors in terms of getting the accurate T category designation. Now, in terms of distance from the carina, it's important to remember the anatomy and distances from the carina of the bronchi. And where it becomes important is in pneumonectomy specimens. Unless there's really abnormal or atypical anatomy in a particular patient, the distance to the carina won't be a concern to you in terms of lobectomy specimens, because the right mainstem bronchus itself is 2 centimeters in length, and the left mainstem bronchus is even longer than that, 5 centimeters. But if we start getting into the concept of a pneumonectomy with a very centrally located tumor, if that tumor is within the mainstem bronchus, particularly on the right side, it would behoove you to have a conversation with the surgeon or the clinician to see how much of the mainstem stump is left in the patient and help you to assess the distance to the carina in terms of getting an accurate T category for that lesion. Now, as I alluded to earlier, understanding what margins are appropriate to report in a specimen really depends on what type of specimen you have. In wedge resection specimens, the margin that's applicable is the parenchymal margin or the stapled margin. But in our traditional lobectomy specimens, we'll have other margins to report, including the bronchial margin and the vascular margin. A new element that we're asking pathologists to report is the presence or absence of carcinoma in situ at the bronchial margin. The data is variable on this, but we felt that there was enough data of interest that clinicians and surgeons should be aware that if there is, in fact, carcinoma in situ at the margin, it may impact on future management of the patient. So we felt it was an important element to be required of reporting. As I mentioned, the parenchymal margin equates to what the staple line is in wedge resections and segmentectomies. And in some cases of lobectomies or bilobectomies where there's an incomplete fissure that the surgeon needs to staple, or the area of the mediastinal pleura that needs to be stapled to extract the specimen, those should be treated as parenchymal margins. And if tumor closely approaches that, what in my practice I do is carefully remove the staple line and ink the en-face cut surface beneath that will help me to assess, when I take sections, the distance of tumor to those parenchymal margins. Another thing that we're asking is that if all the margins are involved, it's helpful in particular to radiation oncologists to identify what margin is closest to tumor and the distance to that margin. That may help them to tailor their fields in patients who are going to be receiving radiation therapy. Note that the pleural surface is not a margin. There is sometimes confusion with that, but it should not be treated as a margin itself. And I should specify that that's the visceral pleural surface. Certainly, again, if the surgeon takes an en bloc resection in which he's including a portion of parietal pleura or chest wall, that's an entirely different aspect. But just in an uncomplicated lobectomy specimen, the visceral pleural surface is not a margin. Moving on to treatment effect, there have been a few studies that have looked at treatment effect cutoffs and how to report them in patients with carcinoma of the lung. So what is being asked is to give a global assessment of how much viable tumor remains in patients who have received neoadjuvant chemotherapy or radiation. Remember, as with any other tumor in any organ site, in such cases to include a Y prefix when you're reporting your T category. This is one example of a tumor that received very good response, in fact, complete response to neoadjuvant treatment, in which we have one of these squamous cell granulomas as a footprint of where tumor used to be in this patient. In this case, one would report the tumor category as YPT0 at this point to indicate that no residual carcinoma remains in this patient. Other features that appear in the AJCC staging but are not always apparent to the pathologist include tumor-associated atelectasis or obstructive pneumonitis. And for that reason, we are leaving this as an optional element in the CAP cancer protocol. But what it really requires in many circumstances is careful confirmation with either the surgeon or the radiologist to determine the extent of involvement of the lung. In this particular example, this patient had a centrally located tumor that was associated with collapse and obstruction of the entire remainder of the lobe in this case. This may have not been, in fact, applicable or amenable to surgical resection, but if one has a centrally located tumor that they're dealing with in a resection specimen, and there's any question as to post-obstructive atelectasis or obstructive pneumonitis related to that tumor, a quick call to the radiologist may help to resolve that and get the most accurate T category for such lesions. As with many of the other organ sites that you may be familiar with in terms of looking at the new CAP cancer protocols, the cancer committee of the CAP decided that it would be most appropriate to collapse the categories of lymphatic and vascular invasion into one category. Some of the reproducibility with what constitutes venous invasion and lymphatic invasion were difficult to rectify with the prior system, and actually simplifying things may make things easier for individuals. There certainly still persists some literature that arterial invasion is worse than lymphatic invasion. There are other studies that say exactly the opposite. So given the confusion in the literature and the difficulty with inter-observer reproducibility, we've collapsed the category into just one entity at this point. So in a certain way, one thing that's being made easier for you in terms of lung cancer reporting. So one of the last objectives for this topic is to familiarize you with the major changes in the 7th edition of the AJCC staging as compared to the 6th edition, and I'd like to go through those now. As we discussed earlier, the data have really shown that the smaller lung cancer is, the better it behaves, and for that reason, T1 has been subdivided into two categories based on tumor size. Those that are 2 centimeters or less in size are now designated as T1A, while those greater than 2 centimeters but 3 centimeters or less are T1B. T2 has also been subdivided into tumors that are greater than 3 centimeters but 5 centimeters or less than size, and those that are greater than 5 centimeters but 7 or less centimeters in size. Recall that the T2A also encompasses otherwise T1 lesions that show visceral pleural invasion. T3 now includes tumors that are greater than 7 centimeters in size, and the AJCC has downstaged multiple nodules in the same lobe to T3 from T4. In a similar vein, now multiple nodules in different lobes of the same lung are T4 rather than M1. The good news with respect to the N category is that no major changes have been made. We are asking that pathologists try to report the number of nodes received and the total number that are involved. But it's the nodes, in particular, the N2 type nodes, level 7, level 4, nodes at those stations are obtained by mediastinoscopy. They're often received fragmented, and it can be difficult to determine whether the fragments represent one or multiple nodes. So it is acceptable to report those as multiple lymph node profiles that are either involved or uninvolved. The key being there, remarking which nodal stations are involved in terms of are N1 nodes involved or are N2 nodes involved in terms of reflecting the accurate N category. We have left reporting of extranodal extension as optional at this point due to limited data on its clinical import. Because of data showing that different patterns of metastases are different in terms of their overall prognosis, M has been divided into two subcategories. The M1A includes malignant pleural or pericardial effusions. Now, this is an upcategorization from T4 previously. Pleural nodules that are separate from the primary tumor are also included in this category. Contralateral nodules. And M1B is reserved for distant metastases, those that are outside the lungs and the pleura. A final topic that I'd like to touch on that bears special significance with respect to the histologic typing of lung cancers is the Ancillary study section found at the end of the lung cancer protocol. You'll see that the reporting of ancillary studies remains optional, but it's a very hot topic, and I'm sure everyone is getting a lot of requests and interest from their clinicians about these. And this is being driven by the fact that there are some newer chemotherapy agents that are targeted to specific molecular aberrations in tumors, such as the tyrosine kinase inhibitors. Now, the tyrosine kinase inhibitors exploit the EGFR epidermal growth factor receptor mutations that are seen in up to 20% of non-small cell carcinomas. And of the patients that have these EGFR mutations, about 80% will respond to the tyrosine kinase inhibitors. This happens to be a dramatic example in one patient who had widespread disease in one lung that after treatment with tyrosine kinase inhibitors exhibited a significant decrease in tumor burden. Now, unfortunately, the response is not durable, and patients actually go on to develop tyrosine kinase inhibitor resistant mutations and will progress eventually. But the short-term outcomes of patients in terms of prolonging survival and quality of life have been important factors in the treatment of lung cancer. In terms of assessing EGFR mutations, there have been a number of modalities that have been proposed for doing so, one of which is fluorescence in situ hybridization. And FISH has been purported to be to correspond to TKI responsiveness, but some of the data has been conflicting. And what is really felt at this point to be the gold standard is PCR-based mutational analysis. You may find that there are still some reports in the literature and some fervent, ardent advocates of using immunohistochemistry to predict TKI responsiveness to these tyrosine kinase inhibitor drugs. But most individuals who are working within this field feel that immunohistochemistry does not correlate well with responsiveness to the tyrosine kinase inhibitors and really doesn't have an appropriate or clinically applicable role at this time in assessing EGFR mutations for predicting treatment. The other molecular marker that has interest is the KRAS gene. Patients who have KRAS mutated lung cancers do not respond to tyrosine kinase inhibitors, in contrast to those who have EGFR mutations. And in fact, if a patient who has a KRAS mutation is treated with a tyrosine kinase inhibitor, there's some data to suggest that may in fact shorten overall survival in such patients. So it's important if someone's considering instituting this type of therapy with their lung cancer patient to know their mutational status. And like EGFR mutations, it's felt that the gold standard for assessing KRAS mutations is by PCR-based mutational analysis. So I hope we've covered the three main objectives today, and I'm sure some of them have generated some interesting questions will come along regarding them. Hopefully we've been able to touch on some of the rationale and give you some insight as to why certain elements appear as required elements in the CAP cancer protocol for lung cancer and why others appear as optional elements. We've gone over some of the histologic types of non-small cell lung cancer that have some special prognostic or therapeutic significance that would be important to communicate to the clinician so the patient gets appropriate treatment. And finally, we've discussed some of the important changes in the 7th edition of the AJCC manual and how potentially to interpret some of the difficulties with appropriately categorizing lung cancers. So with that, I certainly appreciate your attention, and I eagerly await some of the questions that may have arisen.
Kelly, thank you very much for that lovely presentation. So we have a number of questions that have come in, and ones that are coming in as I speak. The first question is from Joanne Charbonneau. And the question is as follows. In the ASCP presentation on the 7th edition AJCC TNM edition, it was said that we should measure size before fixation. How does the fibrosis/obstructive pneumonia component affect the measurement in this case?
Right. That's a fine question, and most of the time most of the time it won't be an issue, Joanne, and others. It's probably, as you might expect in your practice as well, the minority of cases that have such significant obscuring and surrounding fibrosis or atelectasis for it to really be a problem. But I think there are certain circumstances in which, and we've all had those circumstances, in which you're surprised when you look under the microscope, there's a real disconnect between the tumor size that you felt was there grossly and what's there microscopically in terms of it really being mostly fibrosis or obstructive pneumonia and just being a much smaller tumor than you expected. Technically speaking, indeed, in the presentation that you heard before, it is most appropriate to measure the tumor pre-fixation. But as we, and there is data that there is some shrinkage after fixation. And what I'd refer you to is there's a very nice article by Dr. Kirk Jones on an update on lung cancer staging in Advances in Anatomic Pathology in January of this year. And in that, he gets to that very point of measuring tumor diameter. And he references a study that recently showed that most cases, 90%, didn't change their diameter significantly after fixation. But in that study, there were 10% that led to a downstaging from T2 to T1. But that being the fact, I don't think it's tragic in most circumstances, and in fact, many times isn't practical to measure the tumor pre-fixation. And to be perfectly honest, in my institution, most of the time, unless we did a frozen section intraoperatively, we just do our best with the assessment post-fixation.
Okay, the second question is also from Joanne Charbonneau, and it's as follows. Are different pure adenocarcinoma subtypes in separate nodules considered different histologies for staging purposes?
Okay, so I think the question gets at the issue of, do we call something synchronous primary carcinomas, or are they intrapulmonary metastases, if I'm reading into the question a little bit more. And I would refer you to the interesting paper that I referenced again with Dr. Bill Travis as one of the authors, and as well as numerous studies in the literature on the problem of heterogeneity in lung cancer. More tumors than not exhibit very heterogeneous patterns depending on what part of the tumor is sampled. And as you know, the most common histologic type of adenocarcinoma is the mixed subtype. So that being said, you're going to have multiple different patterns within that carcinoma. I think what we can glean from Dr. Travis's study is that when debating the issue of whether a tumor is synchronous primaries or intrapulmonary metastasis, it's important to keep in mind what the major histologic subtype is within each tumor, and then perhaps also what the second most common subtype is. And although this is not reproduced in the literature yet, this is just a one study. If those two major subtypes are similar, I guess I would say that it's more likely that represents an intrapulmonary metastasis than two synchronous primaries. Other colleagues of mine would argue that we should always try to give the patient the benefit of the doubt, and unless there's strong evidence to the contrary, assume that things are synchronous primaries and stage them as such. So it really is still a gray area that we struggle with on a day-to-day basis, and you just really have to make a judgment call. And in certain instances, I think I make a comment in terms of what I see and how I drew my conclusion as to whether something is synchronous or intrapulmonary metastasis, and leave it for a interdisciplinary conference discussion or a call to the clinician expressing that difficulty.
And there's another question from Dr. Charbonneau as well, and it's on a related matter. Is there a minimal distance for separate nodules in order to consider them as two distinct neoplasms?
Right. Yes, this is probably akin to issues that come up in breast cancer as well. And I am not aware of a hard and fast rule with respect to that. And or in fact, I haven't come across anything that says there's a particular distance. The issue that comes up, and it's not dissimilar to in the breast where we have a continuous duct system that looks like you could theoretically have two lesions, but it being along the same duct system that you're just capturing going in and out of the plane. We have in the lung, as you probably know, the canals of Lambert in which tumor can course through and look discontinuous but be part of the same tumor. And the tumor that's most likely to do that, in my experience, is a pure bronchial alveolar carcinoma. A little bit less likely in some of the other tumors. But I guess from a practical standpoint, what I would say is if there are two lesions and they're a centimeter or less apart, I think what would be my practice is to get some deeper levels or submit some of the intervening tissue to see if there seems to be any type of connection between those tumors and go from there.
Okay, the next question is from Dr. James Couples, Royal Columbian Hospital, and the question is as follows. Will this presentation be available online? If so, will there be Dr. Butnor's verbal presentation? If there is no sound, could it be posted on YouTube? So I think I could deal with this one.
Thanks, John.
The presentation will be available, and it'll be distributed through the same mechanism that we notified everybody about these sessions. So it's going to go out through the National Pathology Standards Committee members for distribution, and also through the Canadian Association of Pathologists members list. And I think the people in various provinces will also use their provincial organizations to distribute the emails as well. And in the emails, there will be specific links to these various talks. And when you hit the link, you're going to go right to a WebEx presentation just like you're seeing today, so you're going to be able to see the slides as well as the audio. With respect to YouTube, I don't think we're going to be putting it on YouTube. However, if Kelly wants to set up something on Twitter, she's welcome to do so. The next question is from Dr. Andre Allaire, and the question is as follows. Do we need to do a frozen section of the bronchial margin on a lobectomy specimen if the tumor was confined in a wedge resection done before the lobectomy in the same surgery time and procedure?
Thanks for your question, Andre. In the specific circumstance that you mentioned, I do not. If it were me, I would not be concerned at all about that. If the wedge resection appears to completely encompass the tumor, I would think that the likelihood of the tumor being anywhere near the bronchial margin in a completion lobectomy would be very low. Now, that being said, there's always that rare case, and in fact, 2 weeks ago, I had one of these cases that they describe as a little footnote in the AJCC manual, that superficial spreading type of squamous cell carcinoma that extends proximally but is limited to the bronchial wall, that really went everywhere and was somewhat unsuspected. But I think that's such a rarity that if your wedge resection appears to encompass the entire tumor, the exercise of clearing the bronchial margin at the same setting would be low yield, and it would be very unusual to turn up a positive after the fact.
Okay, we have a question that's a blank from Dr. Blair Walker, St. Paul's Hospital. So maybe Blair, if you could re-enter that question in the chat window, that would be great. Another question from Joanne Charbonneau. The CAP checklist still doesn't talk about the parenchymal margin in lobectomies, which means the staple lines radiating from the hilum when there is an incomplete fissure. In my experience, it is quite common, and albeit rarely, it is sometimes involved.
Right. I agree that you should treat the staple line in those lobectomies in which there's an incomplete fissure, or there are adhesions, or the surgeon is having difficulty without using a stapler to extract the specimen from the mediastinal pleura. That should be treated like a parenchymal margin in any other specimen. And I think in the notation F on page 11 of the protocol, in the middle of the paragraph there's a little verbiage to help you along with that particular issue.
Okay, we got the question now from Blair Walker, St. Paul's Hospital. Its question is as follows. Near the hilus of the lung, where does the mediastinum begin?
Wow, thanks, Blair. That's kind of almost a philosophical question there. We could spend quite a while on that, but I think the key and the take-home there is that, and I've had extensive discussions about this particular aspect with Dr. Travis, who in fact was the lead pathologist on the AJCC lung cancer staging committee, in terms of how can we help our pathologists accurately assess the aspect of tumor extension. And his response, and I think it was helpful to me, is that If the surgeon is working with a tumor that's approaching the mediastinum and they are in fact taking portions of mediastinum, it's difficult for us at the cutting bench to understand what's mediastinal tissue because there aren't particular anatomic boundaries that really stand out for us. So this is, again, one of those instances where there needs to be close communication between the surgeon and the pathologist saying, hey, I took some mediastinal fat or some other particular mediastinal structure that's adjacent to or appears to be involved by tumor, for them to maybe suture that particular area so that you know it's a margin of concern and can address it appropriately. And it's, of course, hindsight is always 20/20, and sometimes this comes up when you're doing your interdisciplinary tumor board conferences, and it gets asked then, and only then do you find out that they really were taking part of a mediastinal structure. But if anything, I think if the growth bench looks atypical or funny when the specimen starts to be cut in, then's the time to maybe give the surgeon a call and just confirm with them that it was either an uncomplicated lobectomy or pneumonectomy specimen, or in fact they were doing some sort of en-bloc resection in which you need to treat the margins a little bit differently.
Okay, now there's a question from Jeanette Lajoie, and the question is, will the deck of slides be distributed later? And I think I've answered that it will be distributed through probably multiple different sources. Next question is from Dr. Onescu from Vancouver, BC Cancer Agency. What criteria are you using to differentiate in resected specimens small cell carcinoma from large cell neuroendocrine carcinoma if nucleoli are allowed, no molding, meaning more cytoplasm?
Well, thank you for that question, Dr. Ionescu. Let's see, as you might expect and as everyone can appreciate, that's probably a whole hour onto itself. But in these types of specimens, there certainly are some tricks to the trade that you can work with in terms of distinguishing small cell from large cell neuroendocrine carcinoma. But again, if you look at the papers on inter-observer and even intra-observer reproducibility, there aren't always times that everyone agrees on which is which, and there is still a continuum. Mainly what I'm trying to get out to people who may be unfamiliar with having seen a resected small cell carcinoma is that because there isn't as much crush artifact, you may be able to see visible nucleoli. And there was a paper by Dr. Mary Beth Beasley, I believe as the lead author, and with Dr. Travis on that as well, looking at resected small cell carcinomas from the ASIT files back in the either late 1990s or 2000s that were documenting that point. But if you start seeing very obvious nucleoli with more abundant cytoplasm, that would be the time to think about large cell neuroendocrine carcinoma. Unfortunately, there are not really a magic battery of stains that will help you with that distinction because we know that there is a spectrum of tumors. It certainly would be nice if we were talking in a couple of years from now if we could move away from the non-small cell or large cell, small cell distinction to just calling these a family of neuroendocrine tumors. But that's another contentious topic that I'm not sure that we will tackle.
Okay, the next question is from Dr. Helwani in Scarborough, and the question is as follows. Is a diagnosis of adenosquamous carcinoma acceptable, and with what criteria?
Thank you, Dr. Helwani, for that question. And it certainly is an acceptable designation. And with respect to the criteria for that, the WHO requires in adenosquamous carcinoma for there to be distinct areas of unequivocal glandular differentiation as well as distinct areas of squamous differentiation. And although there's not necessarily hard data for it, I believe that the WHO requires that at least 10% of each component present, meeting those criteria to call it an adenosquamous carcinoma.
The next question is from Mark Dupree. As follows: regarding visceral pleural invasion, interpretation of the elastin stain can be difficult. What type of wording do you use to report cases of difficult interpretation? And it says, brackets, Dr. Anna Cianco, hi, Kelly.
Great. Thank you very much, Dr. Dupree, and hello to Anna as well. The last time I heard she was down in Texas, so I'll have to make sure she's there. But nonetheless, Dr. Dupree, this is a difficult area that certainly sounds like it's giving you fits as well as it does everyone else who wrestles with these cases. The kinds of verbiage that I include in a report when I truly struggle with a case and really do want to call it indeterminate is that the tumor shows adjacent elastosis, making assessment of pleural invasion difficult. But I will try to tip my hand one way or the other. And I think what's come out now that some criteria have been laid down for what constitutes visceral pleural invasion is that we really want to be very conservative in our assessment of visceral pleural invasion based on those guidelines. And unless we see unequivocal penetrations through an elastic layer is to retain it at the lower T designation. And I fully appreciate that being said, that there are just some of those cases that you don't feel good one way or the other. And I would, since we're still getting used to the staging system, I would put that in a comment that it's indeterminate, and particularly for lesions that are otherwise T1, say as much as, it has some of the features suggesting that this might be more appropriate to treat as a T2A lesion, but because it's not equivocally demonstrating visceral pleural invasion, we'll retain it as a T1. Going a little bit further, the good news is that unless the patient has nodal metastases, at the present time, in most centers, T1 N0 lesions and T2A N0 lesions are still managed surgically alone without adjuvant therapy. So although I like to make things as accurate as possible, the distinction or that break point isn't necessarily going to change management exceedingly so. So it's not quite as an important distinction in those rare cases where you're having difficulty as it would be, say, a different type of breakpoint distinction in terms of the staging.
Okay, another question from Dr. Joanne Charbonneau. Is P63 TTF1 profile accepted for the specific diagnosis of adenocarcinoma and SCC when there is no morphologic differentiation? There are starting to be some therapeutic implications.
Right, Joanne, and this is exactly the kind of battery of stains that I use in transbronchial biopsies, where you're even less apt to find those telltale features of differentiation. And, there's going to be the rare case that doesn't read the textbooks in terms of that, but for the most part, you can feel reasonably comfortable that a tumor that's TTF1 negative and P63 positive, or using another squamous marker such as CK5-6, for example, you can feel reasonably confident that that is, in fact, a squamous cell carcinoma. The reverse profile TTF1 with P63 negative is a little bit more difficult in terms of you have to integrate that with the morphology. You may want to also include with that a mesenchymal stain. Certainly if you see those mucin vacuoles, it will lead you down the path of adenocarcinoma. But if not, it's back to morphology on the H&E and perhaps some ancillary stains to further support your diagnosis in terms of whether you're going down the pathway of a large cell carcinoma versus adenocarcinoma. But that's a fine panel, and I use it regularly, particularly on smaller biopsies where the distinctive features might not be as apparent.
Okay, we have a question from Dr. Butnor, University of Alberta. Do you mention micropapillary carcinoma in the diagnosis if it is only seen focally? Do such tumors carry a worse prognosis?
Very excellent question, Dr. Butnor, and I think the data is still not entirely clear on how much micropapillary one needs to get one over the hump of having a worse prognosis. What I've seen out and about in the literature is that if the tumor starts showing clear-cut features of micropapillary carcinoma in at least 10% of the tumor, that would be the time to really mention that. And I think you'd really be doing the clinician and the patient the best service possible to say that there is a micropapillary component in this tumor. And if you felt it appropriate to qualify that it's a small percentage, but it still is present, that would be certainly would be the best way of serving the patient. And I think the data is there that if it's convincing micropapillary features, even if there's a very small percentage, I choose to go on the liberal side and mention that in a comment.
Okay, we have a question from Dr. Ionescu from Vancouver, BC Cancer Agency. Could you please comment on the use of the large cell carcinoma diagnosis, brackets classic or undifferentiated type, in small specimens, brackets surgical biopsies or FNA biopsies?
Sure. Thanks, Dr. Ionescu. As I'm sure you've heard others talk on this subject at national meetings, the large cell carcinoma category certainly is a wastebasket category, and we're trying to emphasize to people to stay away from the category unless you've exhausted all the other possibilities. But as you know, and everybody's familiar with on these small biopsies, it often seems to be the most satisfying diagnosis. I think it's the way to go sometimes on a small biopsy. If one cannot get to evidence of squamous differentiation, say in the form of P63 or CK5-6 or cytokeratin 34-beta-12 positivity, and if one doesn't feel comfortable that there is good evidence of adenocarcinoma differentiation in terms of strong TTF1 staining or mesenchymal positivity, it may be best, although I don't advocate using the term non-small cell carcinoma in small specimens, to use that term with a comment and saying that it may represent indeed a large cell carcinoma, but a definitive classification is best reserved for the excisional specimen. And I think in that fashion we're not necessarily doing the patient harm, and the key there is one of the reasons that you may be familiar with to recognize squamous differentiation on these small biopsies that I didn't touch on today is the VEGF agent Avastin has been shown to be associated with life-threatening or fatal hemorrhage in patients treated with this who have a predominant squamous histology. So one of the key things that we should be doing for our patients on these small biopsies, at least trying our hardest to say whether we see squamous differentiation or not, so that we don't go down the path of the patient being treated with Avastin and then developing consequences thereof.
Okay, we have two final questions. The first one is from Dr. Bill Chapman, St. Joe's Hospital, Toronto. Should we as pathologists be selecting cases for PCR for EGFR? If so, with what criteria? Or on the contrary, should we dissuade clinicians from requesting it if the histology is unlikely to be EGFR positive?
Dr. Chapman, that's a fantastic question. I think all of us are wrestling with. We all get phone calls from our clinicians requesting all of these various tests on the specimens. And I think it's, for now, very institution dependent, and it really depends on what your practice is and what your clinicians are like. It really ranges the spectrum from people I've talked to. At some academic centers, the tumors are automatically, reflexively tested for both KRAS and EGFR mutations, just as breast cancers are tested for HER2. And at other institutions, such as mine, I await the clinician's call on particular cases in which they've run out of other options and are now considering treatment with tyrosine kinase inhibitors to consider EGFR testing. And it's at that point I can guide the clinician's hand, and in a circumstance where clearly the tumor is mucinous, I can say, it's very unlikely that this patient will have a TKI-sensitive mutation. Do we want to rethink this? But, most of the time, other than that, the data of which tumors do show EGFR mutations is not quite as robust as which tumors do not show EGFR mutations in terms of the histologic criteria. Certainly, as I mentioned, BAC is associated with EGFR mutations. Papillary seems to. But even the most common subtype, mixed adenocarcinoma, is associated with EGFR mutations. So unless it's mucinous and I kind of get them to step back and rethink things, if they do really want to request it, I'll certainly honor that request and send that case out for PCR analysis.
Now, the final question we have time for today is from Raymond Mong, and it's as follows. Is it important to differentiate between small cell versus large cell neuroendocrine carcinoma?
Another fine question on a topic that's difficult to answer succinctly, and doesn't necessarily have a short answer. As I mentioned, it used to be very black and white between small cell carcinoma and non-small cell carcinoma, with even large cell neuroendocrine carcinoma being one of the non-small cell carcinomas. But as we've learned more about the molecular pathogenesis of these tumors, and that it is in fact a spectrum within neuroendocrine tumors, it's less easy to answer that. And I think now, especially, that the AJCC is recommending that small cell carcinomas be staged like non-small cell carcinomas. The distinction may not be as critical as it once was. And if we look at the data on the treatment and outcomes of large cell neuroendocrine carcinoma, the numbers of actual cases are so small, relatively speaking, that it's difficult to make definitive conclusions about them in terms of how they differ in treatment response and survival from small cell carcinomas. So when we get one of those, the clinicians actually really, most of the time, don't know what to do with that, even though we still lump it in the category of non-small cell carcinomas. I would just say to do your best with those kind of cases, and still, if you feel that it does not meet the criteria for small cell carcinoma and has neuroendocrine differentiation, does not show evidence of squamous or glandular differentiation, and with the proviso that you feel it's malignant, that is to say it's not, for example, an atypical carcinoid, you should still try to make every attempt to put it into the category of large cell neuroendocrine carcinoma. but recognizing that there certainly can be some inter-observer variability with that difficult distinction.
Okay, thank you very much, Kelly. Just a few closing remarks now before we shut down the teleconference. On behalf of the Canadian Partnership Against Cancer and the National Staging Initiative and the Canadian Association of Pathologists, I would really like to thank Dr. Kelly Butnor for a truly comprehensive, informative, and incredibly clear presentation today. This is our first conference in the series of CAP checklist presentations, and I'm sure there are lessons that we need to learn from this initial conference. And we would certainly welcome your comments and suggestions. If you could please send them to the following email address, pathology@partnershipagainstcancer.ca. I regret that we ran out of time to answer all the questions today. As some of you may know, the Canadian Association of Pathologists is actively working to sign a memorandum of understanding with the College of American Pathologists that would see additional Canadian input into the checklist via the CAP Cancer Committee and the CAP Protocol Review panels. Possibly in association with that, we could have mechanisms to deal with additional questions that would be more protocol-specific as well. As a reminder, both the live and the recorded presentations are eligible for continuing education credits. The evaluation form for this presentation was previously distributed. Please return the form electronically to pathology@partnershipagainstcancer.ca in order to claim your education credits. Once the WebEx recordings of this presentation become available, it will be made available for wide distribution through the Partnership's National Pathology Standards Committee and the Canadian Association of Pathologists. Access to the recording will be available for review at your convenience and is not restricted. And finally, I'd like to thank the members of the CPAC National Pathology Standards Committee for their valuable input, their time and assistance in making this event a success. Our next presentations are scheduled as follows. Tomorrow, January the 28th at 1 o'clock Eastern Standard Time, we have Dr. Peter Humphrey talking about the prostate checklist. On February the 22nd, once again at 1 o'clock Eastern Standard Time, Dr. Susan Lester will give an overview of the new CAP checklist for breast. And on February the 23rd at 1 o'clock Eastern Standard Time, Dr. Kay Washington will give an overview of the new CAP checklist for colorectal cancer. We look forward to seeing you at those presentations. Once again, I thank you for your attention, and I call this teleconference to closure.